Let's go into life extension and health span a little bit here. Living long, of course, is one thing, but as you've heard our previous panelists say, and everyone, I think, has agreed, what most of us really want is to stay youthful, mobile, and healthy. That's the real goal. Our next speaker, Osman Kibar, a leader in the field of regenerative medicine, will discuss a potential for the Wnt Pathway, he'll explain that, to help reverse conditions relating to aging. Dr. Kibar.
Thank you. Thank you. So before I talk about what we're working on, I'd like to give a quick background on the biology of our platform. We're all familiar with embryonic stem cells. So when the first fetus is formed, the egg meets the sperm, we have our first embryonic stem cell. And then as the fetus grows, embryonic stem cells multiply, become more embryonic stem cells, and at some point, they coordinate and communicate with each other, and they partially differentiate to form all the different progenitor stem cells. So that's the middle layer in this picture. Each progenitor stem cell is in charge of a particular system in the body. For example, mesenchymal stem cells are in charge of the musculoskeletal system. So they can further differentiate and make bone, cartilage, tendon, ligament, but they don't make any skin cells or heart cells or anything else. And then all these progenitor stem cells further differentiate and form all the various tissues and organs in the body. And we have our complete body. Once the baby is born, all the embryonic stem cells are gone. The progenitor stem cells, however, remain in our local tissues until the day we die, and their job is to repair and replenish all the various tissues as needed. And the way they do that, there is a pathway. First of all, let me take a step back. A biological pathway is a collection of genes, proteins, enzymes, peptides. So when they all function together, they satisfy a certain role in the body. In this case, there's a key developmental pathway called the Wnt Pathway, W-N-T. And depending on which way the Wnt activity levels are modulated, that tells the various progenitor stem cells to make what kind of cell, what kind of tissue, when, how much, and then more importantly, when to stop. Now, there's one key aspect of the Wnt pathway, and that is, first of all, it's in charge of all stem cell proliferation and differentiation. And from an evolutionary biology perspective, it's an extremely well-conserved pathway, which means all the proteins and genes that make up the pathway are not just similar, but identical, all the way from fruit flies to humans. So that when we target this pathway to develop drugs against various diseases, we have the luxury such that, say, if we grow cartilage in a rat, we know with full certainty that the same molecule is going to grow cartilage in dogs, monkeys, and humans alike. So going back to biology, as we age, due to lifestyle choices, due to genetics, injuries, whatever the cause may be, the Wnt signaling levels start drifting out of balance. And every time that happens, there is a disease associated with that. So if the mesenchymal stem cells are not making enough cartilage, we develop osteoarthritis. Not enough bone, osteoporosis. Too many colon cells, now we have colon cancer, and so on. What we do is we develop small molecule drugs that are, as the name implies, small enough to penetrate into cells and into the nuclei, and bring the Wnt levels back into a healthy range by modulating specific targets in these stem cells. And at that point, the body's own machinery takes over. We don't have to get involved from there on. Once the Wnt levels are restored back to healthy levels, both the hardware, the software, everything's in place. These progenitor stem cells know what to do. They've been doing it all our lives. So they just get jump-started, and it's a chain reaction. And they restore the health of the particular tissue. So To provide some examples, some of the programs we're working on. One program is osteoarthritis, where with a single injection, we are able to regenerate the cartilage back to a healthy level. So in these pictures, on the left, you're looking at the front view of a healthy animal's knee. So the red in the middle is the cartilage, white is the knee joint between the bone above and below. Then in the middle picture, the cartilage has worn out, bone grinds on bone, inflammation sets in, and these animals develop osteoarthritis. With a single injection, we are able to replenish the cartilage tissue, the inflammation is suppressed, and one key aspect of this regeneration is that the newly formed cartilage is that of a healthy young animal's cartilage, because stem cells don't know how to regenerate old cells. This is the same program. This is a human X-ray. Again, on the left picture, the right corner is the inside of the knee. This is about 60-year-old patient. His cartilage has worn out, so the bone above and below come closer together, and there's a corresponding opening up of the lateral, of the outside of the knee. Again, single injection. On the inside, we grow cartilage on the order of millimeters, and there is a corresponding decrease on the outside of the knee, so the whole knee tilts back to a healthy angle. Another program is for oncology. In this case, we have a pill that goes everywhere in the body, and in this example, this is the cross-section of an animal's colon. On the left, you see all the tumors. And these animals were genetically modified such that they have the exact same genetic mutation that causes colon cancer in humans. And then after we give the drug, you see the improvement on the right side. Everything goes back to a healthy operation. And then we tried this on different types of cancers. In each one of these plots, at the top, I don't know if you're able to read, we have 8 different cancer indications: colorectal, pancreatic, triple-negative breast, liver, gastric, endometrial, ovarian, and lung cancer. In each case, we took primary human tumors and implanted them into animals, and with the same pill, with the same dosing, here the y-axis, the vertical axis, is the size of the tumor, and the horizontal axis is time over a matter of 3 weeks. The red line, the tumors grow when they're untreated, and when we do treat the tumors, we are able to reverse tumor growth and eliminate the tumors, both primary and metastatic. Another program, this is degenerative disc disease, basically disc in our spines. Again, on the left, you see the disc of a healthy but old animal. In the middle, the disc is completely destroyed. Then on the right, single injection, and we are able to regenerate a whole new disc. Another program, this one is for tendon repair. So this is, Achilles tendon, rotator cuff, tennis elbow, tendon in any joint. Again, on the left, you see a healthy tendon. You have these thin, long filaments. In the middle, the structure is lost. The immune cells have penetrated the tendon. And this drug, it's a lotion. You put it on once a day, and we are able to repair the tendon back to normal. Another program, pulmonary fibrosis. On the left, you see a healthy lung tissue. Those hexagonal shapes are the air sacs where we breathe in and out and exchange oxygen and carbon dioxide. The middle picture shows a fibrotic tissue, basically scarring of the lungs. And then this time we have an inhaler. You inhale the drug directly into the lungs, and you see the picture on the right. We are able to, again, restore the health of the lung tissue. And then this is another program. This is basically baldness. On the left, this is the side view of the skin. You see at the top, that's the top layer. And then the small pink dots are the undifferentiated dermal stem cells. Again, this is a lotion. You put it on your scalp once a day. And those dermal stem cells first multiply, then they differentiate into hair follicles. Those hair follicles migrate to the surface, and the thin red lines at the top of the picture are new hair follicles coming out of the skin. And this is the last program I'm going to talk about, Alzheimer's. Again, on the left, you see the slice of the brainstem of a healthy animal. The one in the middle, all those dark spots are neurofibrillary tangles. So these animals have developed Alzheimer's. And then we have a pill, a different pill, goes through the blood-brain barrier, accumulates more in the brain than in the blood, and over time is able to reverse the damage done to the brain tissue. So this Alzheimer's disease is going into the clinic later this summer. Every other program I've shown is already in the clinic, in human testing. Within this year, osteoarthritis and alopecia, that's the baldness, those are going into phase 3 pivotal trials. That's the last stage before we seek an approval from the FDA. And then next year, we're going to put oncology and pulmonary fibrosis into pivotal trials. And we basically employ an assembly line approach. Every year, we put in 2 to 3 new diseases into the clinic. And as they progress, we bring in new ones. So we all get older. We all age. And as we get older, obviously, our health declines. And our approach is that we go after natural targets in the body, and we use the body's own machinery, both hardware and software, and we are able to bring the specific Wnt levels back into a healthy range, at which point we are able to eliminate the various diseases and restore the health of specific tissues one at a time. And by doing that, first of all, we are able to live younger. That's improving the quality of the life. That's the health span component. And of course, as we are able to eliminate one disease after another, we are able to extend our lifespan and get to live our natural lifespan altogether. Thank you.
I got a lot of questions. And Osman, forgive me, but wearing my journalist hat, my job is to be a skeptic.
Please.
Okay? And, you know, we always say if something looks too good to be true, it probably is. So let's start with data, studies and data, because that's what everybody has been talking about and going back, and this is how we can, this is the only way we can make sure that these things are real. What do you have?
Okay, so starting from the beginning, we started operations about 10 years ago, so we've been at it for a long time. First 8 years, we operated in stealth mode. We knew the potential of what we had discovered. So we never published, we never included our targets in any of the patent applications, none of that. After 8 years, this is about 2.5 years ago, we decided we have enough of a head start that we should start publishing our data. So over the last, starting November 15, so about 2.5 years ago, over the last 2.5 years, we have made about 70 conference presentations. These are all peer-reviewed medical conferences in 7 or 8 different disease indications. So we started putting our data, both clinical and preclinical data, out there. And our clinical data, this is all FDA compliant, under FDA guidance. You know. And then, during this time, we currently have, including Alzheimer's, we will have 8 different disease programs in human testing. So we go through the regular phase 1 safety studies, phase 2 efficacy, and then go into phase 3 pivotal studies. So all our phase 1 and phase 2 studies are blinded. So the doctor doesn't know who's getting the treatment and who's getting the placebo. The patient doesn't know. We don't know. This is all under proper clinical trial guidance. So, for example, our osteoarthritis, we did a phase 1 for 60 patients. We completed a phase 2 for 450 patients. And this week, was the last patient last visit for our phase 2b trial for 700 patients. So we've already injected more than 1,000 patients for osteoarthritis alone. And now that we are looking, we are going to look for, seeking approvals over the next 2 years, starting in the next 2 years, we've decided to publish our science, the underlying science, both the targets, chemical structures, etc.
You need to do that.
Exactly. So we have already published 2 journal articles. And over the next 12 to 15 months, we have another 34 in preparation right now. So we're opening up.
So you've gone through these phase 1 studies. Tell me about safety, because anytime you start putting things in here, you always worry about off-target effects, side effects.
Yes. So first of all, whenever we can, we deliver these drugs in a local manner, such that if we don't have to flood the body with the drug, then we don't. For example, to grow cartilage, we only need to grow cartilage in the knee, in the particular joint. So we designed it as an injection. Exactly. So in our phase 1, we actually front-loaded all the safety data. So up until now, we have dosed about 1,400 patients in total to date. We have not encountered a single drug-related safety event, not a single serious adverse event. The molecule is indeed undetectable in the blood. And in our body, in our phase 1, we did every imaging modality there was. We did X-ray, MRI, CAT scan, DEXA for the treated knee, adjacent hip, untreated knee. So we looked at everything that we could look at. After that, FDA said, okay, this is safe, you can move on. So starting with our phase 2 and onward, they told us we don't need to do any of those imaging anymore. We're only doing X-ray for efficacy at this point.
Because we were talking about this before, and I want to make sure that people understand. You have developed a different small molecule for these different diseases or conditions.
Correct.
How do you decide? How do you decide, or how do you generate that small molecule for tendon regeneration versus colon cancer, for example?
So our secret recipe is we identified a number of novel biological targets that people don't even know they belong in the Wnt pathway. So we're working on...
these targets are on these progenitor cells?
They're all nuclear.
Okay.
They're in every cell. Mm-hmm. Stem cell, progenitor stem cell, adult cell, they're in every single cell. But these are all related to development. So if it's not a stem cell and our drug goes into an adult cell, then our drug is inert. They don't do anything to those cells. That's why we get the safety margin. And in this case, we have identified to date 8 novel targets. So depending on which tissue is diseased or damaged towards what, is it the mesenchymal stem cell and they're not replenishing enough cartilage or bone or tendon, depends on what the disease is. We have discovered, worked out, which combination of those targets need to be modulated and upregulated or downregulated. So we develop a small molecule drug that does exactly that. So our small molecules can effectively communicate with any progenitor stem cell in any tissue of the body and trigger them down any lineage towards restoring the health of any particular tissue.
Okay. So tell me now then, you said some of this is, for example, a joint injection. Some are actually oral.
Correct.
Some are lotion and absorbed that way. How do you, tell me about the systemic absorption then from this. You're not getting systemic absorption that might give you a problem.
Yes, so for example, going back to our osteoarthritis program, that's our most advanced. We designed it as an injection because we only need the drug in the joint to grow cartilage. And the way we designed it, we inject it, it stays in the joint for about 6 months, during which it regenerates the cartilage back to a healthy level. And then over time, it diffuses little by little out of the joint. And the chemical properties are such that the lymphatic system picks it up, bypasses the whole body, and deposits it into the stool. So you excrete it at the end of each day. And furthermore...
For some people. Sorry.
And furthermore, in the knee, we designed the molecule. I'm getting into a little bit too much detail, but we designed it as a hydrophobic molecule. So it doesn't like to stay in the liquid. So when we inject into the synovial fluid, it immediately diffuses to the surface of the bone, which is exactly where the mesenchymal stem cells reside. So there is a natural targeting of the molecule onto the cells. And then we did safety studies. For example, in one case, we injected 2,000 times the efficacious dose directly into the blood. After 30 minutes, it was undetectable in the blood because it has a half-life on the order of a couple minutes. So it exponentially decays.
So if I can sort of summarize, if I understand correctly, you know, in neurology we speak of the final common pathway. This is sort of a common initial pathway that leads to, you know, all the roads lead from Rome or to Rome. But this is a conserved genetic pathway that then will stimulate the native progenitor cells, or adult stem cells as we sometimes call them, and let them do the actual healing, if you will.
Correct. So from an evolutionary biology perspective, you can think of Wnt as tissue health. So the first time a single-cell organism evolved into a multi-cell organism, the communication between those cells was done by the Wnt signaling pathway. That's the full name. So whatever worked, nature kept, duplicated, and that's why we get the strong conservation right now. And the first Wnt gene was discovered in the early 80s. For the last 3 decades, if you do a search on the pathway now, you get about 30,000 articles. So there's no shortage of scientific information. It's just that people had been chasing the wrong targets and therefore were never able to achieve safety and efficacy at the same time. Thanks to our novel targets, we're able to do that.
Clearly, we're all going to live forever. Thank you. I mean, that's really fascinating, and hopefully it will work out that way as being the real deal, and that we will live longer and healthier. I have more good news. It's lunchtime. We will see you back shortly.